formally, despite the debates, renamed the AMERSA Discourse because dialogue is how we learn, right? Stories, dialogue, information. And so I am so happy to turn over the panel introduction, but also some of the norms of our discourse to Michelle, and then we will go from here. So thank you.
I'm a psychiatric clinical pharmacist supervisor with the San Francisco Department of Public Health. Very involved with our buprenorphine and methadone. Yes, thank you. And I also will be introducing our lovely presenters, Dr. Dennis Antoine, as well as Dr. Ruth Pote. Okay. We'll start with our objectives. We're going to outline alternative approaches to methadone dispensing. We're also going to examine the anomaly of 42 CFR 8.12 in the Opioid Treatment Program regulations. We're also going to summarize the potential harms of prescribing methadone to pharmacies for opioid use disorder. So let's start with introductions of our presenters. So our first presenter is Dr. Dennis Antoine II. He's board certified in both psychiatry and addiction medicine. He has spent 20 years in Baltimore involved in the treatment and research of severe substance use disorders and co-occurring conditions. He is currently the director of a methadone clinic and a community-based clinic with office-based buprenorphine. We also have Dr. Ruth Pote. She's a family and addiction physician. She has provided direct client care for 25 years in rural and urban settings. She currently oversees 5 methadone clinics, including one at a county jail in Western Massachusetts. So I want to do some expectation setting before we get started. Number one is this is educational. And that is the main goal of this presentation, is we all come away educated about both the pros and cons of methadone deregulation. And there are no individual winners or losers in this debate because, I'll tell you, we took a unique stance this year. There's 2 prompts and questions I'll be asking as the moderator. And on the first prompt, one of the presenters will take the pro stance and the other person will take the con. And for the second prompt, they will switch, as they've indicated with their t-shirts they're wearing. We're going to hold the questions until the end in designated question times. And then we're also maintaining a safe educational space. Please be polite to others with different viewpoints than your own. No booing, no hissing. And so I'm going to start with a little background on methadone deregulation. I think we're all familiar that we're in the era of fentanyl. There's an opioid epidemic. And that fentanyl and fentanyl analogs are driving the opioid epidemic at this point. And we know we have excellent medications, buprenorphine and methadone, that are associated with improved mortality, not only just from opioid overdose, but all-cause mortality. And we also know that fentanyl use is associated with increased risk of precipitated withdrawal when using traditional dosing strategies for buprenorphine. How we used to use buprenorphine is not working as well as it used to. I want to highlight this study of people with self-reported opioid withdrawal. And this is looking at people on fentanyl, and they either are taking buprenorphine through traditional methods of starting it, or switching to methadone. Quite a few patients were in this study, and not surprisingly, the odds ratio of experiencing withdrawal was much higher in the group with taking buprenorphine. So we know that we have this growing body of evidence for buprenorphine to start it in different ways that are non-traditional. We're looking at low-dose overlap initiations, we're looking at macrodosing, we're trying all kinds of things. I think we're having some success, but we really don't know where that fits in exactly at this point based on the amount of data that we have. So with buprenorphine becoming harder to start and people using fentanyl, access to methadone is imperative to address the opioid epidemic. I don't mean to imply that that necessarily has to mean methadone deregulation, but we have to look at all of the options that we can have to make sure that we have access to this medication and that it is safe and effective. Also want to highlight a current bill that's existing, the Modernizing Opioid Treatment Access Act, or MOTA. It's a bipartisan bill. It was introduced in March 2023. It has multiple pieces, but just a high level. It allows for board-certified physicians in addiction medicine or addiction psychiatry to prescribe methadone for opioid use disorder outside of an OTP. So it allows that piece to be legal. It also allows for community pharmacies to dispense methadone for the treatment of opioid use disorder. It is supported by multiple organizations. I did not put a complete list up here at all, but I wanted to highlight that AMERSA is one of those groups. All right, so that's going to bring us to our first prompt. So for this proposition, Dr. Ruth Cody is going to be for methadone deregulation, and we'll start, and Dr. Dennis Antoine will be against methadone deregulation. They will both have 10 minutes to speak. I will be interrupting and giving them a 1-minute countdown, just so you know. And the first proposition is, what are the pros and cons of changing regulations from an OTP-only model to an OTP and office-based pharmacy model? And we'll start with Dr. Ruth Cody.
So I'm going to make sure the mic's on. Who in this room works in a methadone clinic? Awesome, good work, you guys. Dennis is basically seeing patients this morning from what I could tell in the methadone clinic. But did you guys see in a room filled with people who specialize in addiction medicine, right? If something bad were to happen at this hotel, we would have wiped out a lot of addiction knowledge in the country. Did you see how few hands just went up, right? It's actually interesting that even amongst those of us that are board-certified addiction clinicians, a lot of us really don't know a lot about methadone. Methadone, as my friend Aaron Ferguson says from the Urban Survivors Union from Austin, Texas, is a miracle molecule that no one has access to. This drug, for those of us that have spent a long time in our careers prescribing drugs, this is a drug that changes people's lives. It doesn't just prevent death, which of course it does. It makes your life better again. When you get stable on methadone, you're going to work, you're taking care of your kids, you're shoveling out your mom's driveway. Your life is good again. Notice that I didn't say you stopped use entirely, because that's not actually the relevant part. The question is, have you decreased chaos? Are you not hospitalized? Are you still alive? Are you not incarcerated? Like, those are some of the measures we look at in a methadone clinic of somebody who's really succeeding. So this is a miraculous medicine. And everyone in this room who has a DEA prescribing license should be able to know how to use methadone, use it safely, use it wisely, use it in right settings. And if we're not doing that and training addiction clinicians, we're way behind the 8 ball on that, and we've got to get better. So this is a journal that comes to my house every single month because I'm a family doctor, the American Family Physician Journal, and about every 5 years they come out with an article that talks about medication for treatment of opioid use disorder. This was 2019. The truth is, I am describing a miracle molecule that actually saves lives, makes you healthier, changes your life. There are very few drugs that anybody in this room prescribes that actually do any of that. Shout one out to me that really changes somebody's life dramatically. What was that? Buprenorphine. Done. Okay, what did you do? Awesome. Okay. Give me another one, guys.
HIV meds.
Thank you. Antiretrovirals, treatment for Hep C, life-changing. I would argue birth control. Right? Changes your life, gets you in control of your body. But that represents some small percent of what we all prescribe, okay? This is an article every 5 years in the AFP journal. You have a miracle drug that works this well, you would expect that every pediatric, family medicine, internal medicine, every licensed clinician would know how to use this medicine, use it effectively, and be able to use it, right? And instead, I would say there's more people who use Botox for cosmesis in our country than understand how to use methadone, right? Like, what a failure of the system at every level. Medical school, pharmacy school, nursing, everywhere is not teaching this. You ask the average first year, second year medical student what they know about methadone, close to zero. And again, in a room filled with addiction people, I drop you into the methadone clinic, you may or may not know what you're doing. That's not okay either. Number needed to treat, every single day I write blood pressure medicine, and I know those of you in family medicine and primary care do the exact same thing I do, right? The number, and we're measured on it too, right? You get dinged now if you're not like suppressing people's blood pressure until they're fainting. Okay. Number needed to treat to prevent death is 125, right? You have to treat 125 people with, your 6 blood pressure medicines to prevent 1 death. To prevent a stroke, the number's better, I think it's 67, so that's pretty good. And then from a heart attack, I think the number is higher than that. So, that was statins. I'm so sorry, I didn't know. This is my blood pressure medicine. So that was statins before, which again, the number needed to treat with statins is a huge number. And all of us prescribe statins every day as well. So the number needed to treat to prevent death from methadone is 40, but that's old data. That was from 2012, prior to the fentanyl era. So we know that there's at least an 80% reduction in death from using methadone. I find it interesting that's the thing we spend the most time on is preventing people dying. It's extremely important, I get that, right? But let's spend a minute and say the number needed to treat to improve your overall well-being, to give you a sense of control, to reduce your use, to change your use pattern, to be able to save enough money that you could pay your rent. Like, the number needed to treat with methadone, it's like 1. Honestly, for those of us that work in methadone clinics, and for those of us that put our hand up earlier, we see it every single day. You sit down for an annual visit with somebody, and you say, tell me about the ways in which things are going well for you in your life. And you hear the stories that they choose to tell you. Again, drug screens are not relevant to that conversation. And people tell extraordinary stories about the way that their lives are improved because methadone is part of their work. This is the year 1973. That Volkswagen Bug held 5 children and 2 parents. It had no seatbelts, no airbags, it had no snow tires, those pieces of lumber you see lying on the ground. That was how we got traction to get out of our driveway. My brother is 6'3". There's nothing in this picture from 1973 that should still exist. Nothing. The car shouldn't exist. Those clothes and those haircuts shouldn't exist. None of that. And yet, that's what the world looked like in 1973. So happy 50th birthday to methadone regulations. Largely unchanged since 1973. So $100 to the first person in this room who can tell me honestly something in medicine that we still do the exact same way from 1973. You don't have to answer it now. I'm actually going to let you have time on that because it's $100. There's almost nothing. There's really almost nothing that we do today that's exactly the same from 1973, except this. And that should make everybody in this room actually feel like sick and rageful and like, boy, something big has got to change. I don't need to tell you about people who die. You guys have lost family members and patients. Some of us have lost hundreds of patients over decades of our career. This is the number of methadone clinics in our country currently. Those little purple dots, methadone clinic. Look at our nation. We have Missouri showing up in this room in big numbers, right? Big numbers. Look at the center of our country. Look at the state of Wyoming, 0. Look at Texas, right? Texas is 254 counties. You can probably drive 6 hours and not reach a methadone clinic in that state. In order for people's lives to be saved, in order for us to make a big difference in the outcome of our overdose rates, of improving people's quality of life, the country needs to look like this. And there's really only one way to get the country looking like this, right? And that is that we allow the dispensing of methadone from pharmacies written by people who have a DA license, period. It's the only way through this problem. We have Samsa in the room today. She sat here, love her. She's a rock star. Lucky to have her on our side. But the current federal rules, even the new proposed rule changes, hopefully that will be promulgated in hopefully the early part of 2024, are not enough to solve this problem. We are absolutely moving chairs on the Titanic here. So one of the things that the DEA and SAMHSA says is just put your methadone van on the road. Like, that's going to solve all the problems. And I loved all the van pictures yesterday. I took a picture of every one of y'all's vans. I thought they were awesome. But we just bought our first van. That's it right there, right? I have a little YouTube video of our van. $190,000 for that thing. It is empty. It's an empty shell. It has a seat for the driver. That's it. It's going to cost us another $60,000 to outfit it with all the stuff that we have to have in it. The DEA's giving us all kinds of issues about where everything's located. It's fine, we can handle it. But anyway, that's $250,000 to put a van in Western Mass on the road to go serve one of our methadone deserts. That is not a scalable solution to the problem. It's not. We're done with this. We have great pharmacists. We have more pharmacists in this room than I've ever known at any conference. I'm so excited about that. We have really smart clinicians, and especially what we have is new, young, bright, amazing people, all of whom are in this room. And I can't tell you as an old person in this room how exciting it is to know that you young fellows, you medical students, you people who are coming ahead of us are going to take over and are going to run this show, and that you're going to be trained enough that you're going to feel super confident about getting somebody stable on methadone. And we have the drug itself. The drug's practically free, right? Methadone exists. It's been around since the 1940s. And we just need to get the combination of these three entities working together to make our entire state, our entire country, widely purple with widely available methadone for anybody who needs it.
Lawyers speak at the beginning. These views are my own, not views of diversity or anybody else. But I respect Ruth highly, and wanted to put this shirt on because it is a contrast to our views for this first part of the proposition, which is what do we do about this methadone? Do we maintain it as it is with the regulations, or do we think about expanding to the pharmacy? That's the question that we have here. So my stance for this portion is why maintain the regulations the way they are. And I think about some of the patients I've seen in the past 2 days. One individual came to the clinic, terrible laceration in his leg, looks ulcerated, and he says, I'm about to switch to another clinic, and he went to the other clinic and said, well, I need to come back now. And he said, I don't really like what they're doing over there. I like the structure. And it really speaks to the complexity of the care that we have to do. It's not just about the medication. I tell all of my patients that. If we simply say this is about the medication, we are failing. It is much more than that because it's about a coordination of care of different disciplines, nursing to do the triage, psychiatrists to look at the high comorbidity of psychiatric care that is often needed, counseling to actually see how the healing process goes over time, and then training requirements to make sure the person who is leading that ship knows what the heck they're doing. It is not just about the medication. And sometimes if we look at it just as the medication itself, we may be thinking something. I don't even think my shirt belies the conversation to say that methadone saves lives. Treatment saves lives. So within that, I think there's more to medication that we need to think about, which is the overdose potential. If persons are taking other medications like clonidine, gabapentin, things that could combine, we need to think about those comorbidities and potential for this full agonist medication to cause sedation, respiratory depression, along with those other medications, and then think about the new medications that are going on. Who in here has heard of isoniazid? Raise your hand. Okay. Next year, I know it will be all of them because it's starting to be on the rise. Xylazine is the big thing now as well, but maintaining that awareness of what is next is really important. And then up-titrating the medications is a big piece of that as well, because if you go too high too fast, even the medication alone will be an issue. Xylazine, as I talked about, is an important piece of that. And it's important because it's not an opioid. Giving more methadone is not what treats it because it's an alpha-2 agonist. I won't go on and on about that, but all to say it's a different mechanism pharmacologically than opioids themselves. So I've seen cases where the methadone gets ratcheted up. A few people of us have actually submitted a case report about that recently because we thought, oh, let's just give more methadone. This looks like withdrawal. And it wasn't. It was something different. So oftentimes that knowledge needs to be trained and reviewed to make sure we're doing the right things. Otherwise, you might get the wrong treatment. Not just the wrong medication, but the wrong treatment. And the regulations are old. I will not debate that at all, 50 years. And when I came into the methadone clinic that I am now director of, it was right at the beginning of the pandemic. So that was a weird time to come into a methadone clinic. Things changed a little bit, and they changed more, and now we're at the point where there are flexibilities to take homes that should have been there a long time ago. I'll confess to that. But it is still a type of regulation that gives some flexibility. So to say that we should get rid of the changes that just occurred, I think is premature. Because we do need to see how the patients respond, how the clients respond, how the individuals respond to that. And like I said, I have individuals that say, I'm just gonna go down the street, and they come back. That person is not the first person. So have we asked the patients what they want? That's the other piece. What do they think about these changes? Or are we just enthusiastic about a type of change without them? That's very important for us to look at. So I think without that answer, we shouldn't make the change. And pharmacies could play that role, and we should ask them what they think as well, because that is part of the potential shift to say, could we include pharmacies to make this easier? Overall, though, my biggest thing is standardization of treatment. And we need to make sure that it is just, not just in the ethical way of saying, make sure it's right and legal, but is it distributed equally to make sure people get the care they need? Underserved populations are underserved for a reason. Are we going to be doing this in a way that is equally distributed? And does that mean we are not just giving the medication, but making sure the outcomes of the medication are what we want? Is the treatment accurate? Is it impactful? And are we looking to improve how we give that treatment? Methadone regulations right now include required continuous quality improvement. If we get rid of those, no one will have to do anything. And I don't know if that's just. I don't know if we've accounted for that. And also with that, treatment as usual will go out the window. Because at least right now with the regulation of what should happen and how frequently a person can go up and where they start the dose, you know what's going to happen. So if you make a comparative change, you can see what's better or worse. It will be a free-for-all. And that might not be the best way to go about things without knowing what is the standard. Getting to my last 2 points on this topic, on the first question, I do wonder whether we've learned our lesson as well. As we think about deregulating, have we learned our lesson about things like this slide from the National Survey of Drug Use and Health, looking at people who have misused their substances? And mind you, methadone isn't even on here, but where would methadone be if buprenorphine is that? Where would fentanyl be? Would it move down, move up? Where would xylazine be? I know it's not an opioid, but have we thought about where it would end up on this slide? Because it will come. And we didn't see it coming for buprenorphine, but we should think about that for methadone. Have we thought about that? Finally, I want to think about this. Here's a lesson we have not learned. There is a distinct disparity as to who gets the buprenorphine now. We have not learned that lesson or solved that lesson for buprenorphine, so why should we do it with methadone as well? If you have an answer for me, that would be a big piece, because we are pretty much saying we're going to widen this discrepancy. And that is a problem from a justice standpoint, which is all of our ethical principles that we need to adhere to and think about more deeply. If we don't solve that, there's no reason to deregulate, because we might make things worse for the individuals that we're trying to help. So like I said, it's not about the medication. The medication is a great tool. It's an important tool, and I'm all about access, as you'll see in some of my later slides, but this is about what are we doing with the tool and what is the thing that will help this person heal. And so far, we haven't gotten to the deregulated thing, so why should we do it? So I'll stop there.
federal regulation, 42 CFR 8.12. Who's read this? Okay, so again, small number of our hands went up, and actually everybody should read this. I just want to remind you where 8 is. 8 sits between 7 and 9. What is 7? 7 is distribution of reference biologic standards and biologic preparations. 9 is standards of care for chimpanzees held in federally supported sanctuary systems. There's only 2 medications mentioned in 42 CFR. They happen to be like, it's as though 42 CFR exists to have like super effective medicines, such as methadone and buprenorphine, the only 2 medicines mentioned there. That's what 42 has. Every other medication that anybody in this room dispenses or prescribes or ingests belongs in 21 CFR, right? That is the basic problem here, my friends. In 1973, this thing was created where methadone, and then later bu, ends up next to the management of chimpanzees. And it's both funny, and it's actually just horrifying. It's actually horrifying. And I really actually think that 42 CFR 8.12, it all needs to go away. It needs to be struck down. And these 2 molecules of buprenorphine and methadone, possibly other unknown molecules of treatment not yet in action, belong in 21 CFR in the normal section of drugs for human use, subchapter D. That's it. I don't know how to make that happen. I'm just a frontline in the trenches doctor. That's what I do. But people like Ingveld Olsen and government people in this room, this for me is the thing that needs to happen. Just get rid of it. Just get rid of it now. I am going to just spend a minute looking at a map, and that is where methadone clinics are in our country at this moment. And again, the disparity. Look at West Virginia. West Virginia is a state that has the highest overdose. Anybody from West Virginia in our room? Thank you. Excellent work. Because being in West Virginia is not easy. It has the highest overdose rates. It's had some of the worst resources. And I think until very recently, it said no more methadone clinics. They only have 9 methadone clinics in the entire state of West Virginia. Massachusetts, my home state, tiny, tiny little state, has more licensed OTPs than Texas does. It's a little skewed. I acknowledge that those are not publicly facing methadone clinics. You know, all of our jails and prisons in Massachusetts are required to have methadone available. Some of them have become their own OTPs. That's part of that list. If you're an ATS or withdrawal management and you use methadone, that's part of that list. But just look at the disparity of where methadone is available. And again, if you want the whole country to look purple, you can't rely on this system. This system, who's opened a methadone clinic in this room? From scratch, right? It is a nightmare. It just is a nightmare. I've now done 5 of them, and I can't tell you how hard and challenging and ridiculous it is, and how expensive it is to open a brick and mortar methadone clinic. So the problem with having any federal regulation is because part of the federal regulations say that, yeah, we're writing the rules, that's what 42 CFR 8.12 is, but who's in charge of enforcing the rules? The 49 states that have state opioid treatment authorities, the SOTAs. So this is Pew Charitable Trust. Who's Pew in the room? Do we have Pew in the room? Pew is rock stars. I don't know why they're funded, how they're funded, but they pay attention to people with substance use in a lovely way. They do incredible reports, and this is their excellent report on sodas. And so the sodas actually are one of the biggest problems we have. Who in the state's from Tennessee? Okay, your soda, and I'm not just pulling out Tennessee because I could pull out any of the states that do this. You are one of 3 states that maximizes cap dose of methadone, 120. You cannot go above 120 in the state of Tennessee. What? Like, is that based in any science or evidence? Right? How does your soda get chosen? How do they get removed? Who influences your soda, right? Like, who knows the answers to any of these questions, right? Nobody, from what I can tell. ATOD wants to spend its money on lobbying something. Right now, ATOD, and I don't care if ATOD's in the room, I would say this at an ATOD conference. They are spending a lot of money lobbying against MODA at the federal level. They should be investing all their time looking at sodas in states that are getting in the way of people getting adequate treatment. Put their money there right now. So the problem when you have federal regs is then you have state regs. And the state regs, as everybody knows, are often much harder and worse than other places. So this is just a quick map of where there are limits to having any opens of new OTPs. Again, I pull out West Virginia because it's a state that suffered, but where treatment's not highly available. Nearly half of the states require a set counseling schedule, whether there's evidence for that or not. The quality of the counseling is really, some of it is great, some of it is really terrible. People are reading a lot of Bible passages and they count that as counseling, not in my book. This is you can be fired from almost every OTP in the country because you use drugs. What? But there's 2 exceptions, Massachusetts and South Dakota. But otherwise, if you have drug screens with substances in it, they can let you go for your OTP. Really? Does that make sense to any of you? No, of course it doesn't. So until you are going after the soda to make things better for people, we can't rely on the system anymore, right? This 50-year-old system is so broken, it is so hard to work with, it needs to be scratched and we need to start again. We just do. And we treat it like we treat every normal medicine. You learn how to use it, pharmacies learn how to dispense it, and we keep people safe.
1 minute.
I only have one slide from everybody. It's an old slide. It's from Canada, a place that has a little bit more experience than we do about this. And this is a quote from what was happening in 1997. I don't read my slides often, but I'll read this one. However, challenging the stigmatizing views of some medical professionals and of a society at large will require not only better treatment access, but educational and advocacy efforts at many levels. We don't have that, but we're saying we should change now. This was an issue that was brought up in 1997 by another country that was doing it back then. I would say that if we had the education going, if we didn't have the stigma in place, which may or may not be caused by 42 CFR, then we would be ready to move forward. Advocacy, I think, is very large in this room and very important. However, there are colleagues, even with addiction medicine certifications, that have stigma against this, and I've experienced that. Education is not where it should be for these medications. It could be higher. If we're going to spread this nationwide, as we should for access, we need to make sure this is addressed before we go there. Not do it first and figure it out, because this medication could harm some individuals. And access, like I said before, we need to make sure that it is all access. Not just to say that we can do it. We need to make sure that that access is there. COVID showed why that's very important, and there will be something else that comes up. So I would say that knowing other countries who tried this out have pointed out the problems, and we haven't put in an infrastructure that is reliable to address them, is a huge red flag. And we need to pay attention to that before moving forward. Should we change it up? Yes. Are we ready right now? No. That's where we're going.
Wow. So I don't know. I don't think any of the other presentations have lost to each other. Very good. I think that was really compelling on both ends. I love that you both brought up issues about access, equitable access, safety. So I think as we go on, we'll continue thinking about a lot of these issues that come up. So now we've switched. So now Dr. Antoine is for methadone deregulation, and Dr. Cody is against methadone deregulation. And that brings us to our next proposition. So if we deregulate methadone, what will be the impact on the opioid epidemic? Are we going to save lives? Are we going to harm? What are the public health impacts of this? And each speaker will have 8 minutes for this question. So I'm going to start with Dr. Antoine.
blue shirt, who's this? So, I think it's really important to think about what it's been like with the regulations and what would happen if we kept them going. My experience is that I've been at a clinic now that has 108 plus individuals coming for treatment, and no surprise, I do think there would be ongoing stigma if we kept things going the way they are right now. 42 CFR has been a difficulty. Part of the reason I jumped into the OTP world is because one of my patients got kicked out of the clinic because she didn't bring her paper record from another doctor saying that she had a prescription. And I'm thinking, what is this? And 42 CFR is a barrier to that communication. Without that, you can't get the information in the electronic records and have that communication. And we're about to publish a paper that's saying that the patients don't care as much as we think they do. So we should think about that change. If we keep it exactly how it is, that will be a barrier, and we don't want that. More input from the patients are needed as well, because oftentimes it's been the administrators or the directors only who've been giving the information, and we need to do more about that. Then there are health disparities. Again, COVID taught us a lot. Did we learn that lesson? The biggest lesson is a lot of people suffered more than others, and I think access was a big piece of that, and methadone was there for it. It's not about the medication, but the regulations did make it difficult at times, even with some of the relaxed regulations that occurred. So my big concern would be that certain populations by ethnicity here would be the same. And part of it is access, but part of it is stigma. And going back to that 1997 slide. So we can't see this go in the same direction. I can tell you, when this graph was made, that was just the beginning. It's gotten worse. So keeping it the same would be unfortunate. And COVID or not, this is a big issue in terms of overlap of syndemics, which would be that maternal mortality, infant mortality, and adverse perinatal outcomes has always been an issue. And methadone was studied at my clinic initially, but it's still not widely accepted and widely used in the way to decrease these discrepancies, which show that African American women and their babies have much higher rates of mortality and adverse outcomes than we should have. So we can't keep this the same. And women are afraid to show up at clinics because they're worried about reporting, they're worried about what will happen, and oftentimes doctors don't know what to do, or they just say, we can't treat this person because they're afraid of what could happen to them. That can't stay the same. We need more education with that. It needs to change. And in terms of innovation, my own clinic was part of one of the first trials in doing pharmacy dispensing to see how it would go. It was tough to get set up. We're trying to do a second wave of that, but you have to go through a lot of hoops to get the ability to do that prescribing, and I don't think it should be that hard. So I would say that if we kept it the same with all these regulations, you can't do this type of innovation, and we need that now. Access needs innovation, and we need to do it in a regular way. And one way that we're doing it is reaching out to the community, and no one has talked about that. Regulations don't require community interaction or community partnerships, and one thing we're doing at Johns Hopkins is going to a community-based program and saying, look, you're great at housing, you're great at treatment coordination, you may not know what HIPAA is. True story. But we're going to work with you, and we're going to get you there. And, if I had to try to bring methadone down there, I couldn't. It's very difficult because of the regulations, but they have 250 beds for women and children and 400 other beds for men, and it's hard to get methadone there. We need to make that interaction easier, and we need to make sure the regulations recognize how to do it in a safe way. So I do think it needs to change so we can make this better and more accessible. And otherwise, if we keep it the same, it will be worse.
Methadone actually is a really potent chemical. And you actually really need to know what to do and how to dose it. Like, that is real. That's not made up. And in this room, how many people, and so I'm going to actually specifically ask those who are prescribers and maybe pharmacists, feel really confident that you can do an induction on somebody on methadone? Yeah, those are pretty good numbers. Are there any, that is actually pretty good numbers. Are there people in this room, maybe you're a fellow, maybe you're a med student, maybe you're actually an addiction doctor who doesn't actually work in a methadone space, all good. How confident are you? Are there people in the room who aren't confident they could do this? Yeah, there's some people who are like, yeah, I have never done this, right? Do you know when the first time I walked into a methadone clinic? When I was the medical girl. I didn't know a whole bunch about methadone, and I called friends like nonstop. I begged for help. I did what we all do when you're a learner, is you just ask for assistance. I had no idea what I was doing, and we're arguing to actually have the average family doctor out there take this on. Honestly, realistically, I mean, like, first of all, as a family doctor, married to a family doctors right now are super busy, right? They have 27 hours of work to do already every single day. And the last time you called your primary care doctor for an appointment, right? Did you get an appointment? Some of you don't even have a doctor in this room, I know that. And good luck finding one, right? Because primary care is completely overwhelmed right now. And the notion that they're going to step into this space, we know they don't step into this space. They didn't step into the space for Butte, guys. Why do you think this is actually going to work? We didn't stand here and be like, make it happen, snap your fingers. It is not realistic. And the question was, will we actually change outcomes for people with OUD? We might. We might improve the lives of some people, particularly in parts of the country where there's no access now. Having said that, we know that when you have more available methadone, more people will die with methadone in their system, period. Like, there's no one in this room who's gonna out-argue me on that one. I'm not saying methadone will necessarily be the killer. It doesn't matter though. Their toxicology at a medical examiner's office will have methadone in it. And those numbers won't be just in the dozens, right? They will be in the hundreds or thousands or tens of thousands. Methadone will enter into the illicit market, the prescribed market. It will be more widely available and more people will die, often in combination with fentanyl and methadone and alcohol and benzos and any number of other things. But that is a huge risk, to take this most effective drug and all of a sudden set off a bunch of red flags about it. So a lot of us fight back on the, well, methadone kills people, right? Because that data was done back at the time when many insurance companies during the opiate prescribing phase of our last 20 years said, you can't prescribe OxyContin anymore, you have to prescribe methadone for pain, and most of us had no idea what we were doing. And so people were starting folks on pretty high doses of methadone, they didn't know what they were doing, and they were increased overdoses. But when you actually look at the numbers, they're actually kind of impressive. Over a period of 1999 to 2007, thousands of people had unintentional death from methadone, right? It wasn't a good phase, and it leads you to believe methadone can be super harmful to people, especially when prescribed by people who don't know what they're doing. And in a society where lots of people have a benzo use disorder and are drinking too much. The combination's not great, guys. So this really could hurt us. This is actually SAMHSA sort of overall analysis from 2010. And what it shows you is that actually when dispensed from an OTP, the death rate is a certain percent, this is by region, but when actually given as a prescription, the death rate is about twice as high. So again, those are people, right, when it's prescribed, it's not for opioid use disorder, right? We all know that it's for pain, but it can be mismanaged, misprescribed, and people will be harmed. And we know in medicine that the pendulum swings fast, right? We know this because we have caused so much harm by yanking people off of their prescribed opiates who did not have an opiate use disorder, right? But we acted like they did, and we yanked them off. So what did they do? They either killed themselves, they suffered, or they turned to the illicit market. You know, whether you liked what is called the overprescribed time frame of opiates, we at least had a safe supply then, quite honestly, and now we don't. When that happens, when we start to see increased deaths due to methadone, you know who's going to come knocking? This is not the bogeyman, my friends. I actually lie in fear of these folks every day. And the DEA could be in the room and I would say this. The DEA is a real challenge to work with when you're a prescriber. They're a challenge when you're running a methadone clinic, I can tell you that. And a lot of us who feel like we've been targeted by the DEA, I mean, I've had the DEA show up at my office, right back in the old days. I'm an old bupe prescriber since 2002, when they showed up in your office and demanded to see your bupe prescribing books, right? Other people are nodding how terrifying that experience was. We start to see people die from methadone. You think the DEA is not going to light up? Innocent people will die from methadone overdoses. People who do not have opioid use disorder. There will be children who die. There will be family members who die. There will be pets who die. People will die from diverted methadone, period. And that will light up the fire of the DEA. And then what if the DEA actually starts to curtail the use of our most effective molecule, and all of a sudden it starts to be curtailed in a way where people who have opioid use disorder don't have access to it? There is a way this can go very badly. If my room of the ultra experts in the entire country can't do this 100% of the time, do you think the average primary care can do this? No way. This is my rebuttal, I'm going to just say it right now. This little picture of like the happy pharmacist and the happy prescriber and the little pill bottle, this is nuts. And this is not real. None of this will happen, right? I already told you that middle one, the people who are going to be willing to step into the void and actually prescribe, we know they don't exist now. Primary care is broken in this country. You are not reimbursed for this work. I hate to say it, people don't want people with substance use in their waiting room. So the middle one's not going to happen. Let's go to the first one, the happy pharmacist, because it's so easy to be a pharmacist these days. Over half of the pharmacies in a state like Ohio don't carry buprenorphine. We saw a great, I went to the pharmacy session yesterday, it was awesome by the way, and we watched what happened in Philadelphia, where they actually go zip code by zip code by zip code for the pharmacies in the city of Philadelphia, who has more overdoses than any other city in America. The number of pharmacies that don't normally carry or feel comfortable dispensing buprenorphine. You think those pharmacies are going to sign up for methadone? It's not going to happen. I can't even tell you in all the ways that is not going to happen. So you just knocked out CVS, Walmart, Rite Aid, and Walgreens, right? Top four. None of them are signing up for this, guys. None of them. How does it actually happen in Canada? So first of all, let's spend a minute on that one. I'm not going to talk about all the provinces, because you guys know in Canada it's not a federal rule. Every province makes their own rule. But for BC, for British Columbia, first of all, they do dispense methadone out of the pharmacy. They do that, it's a fact. They actually have you come every single day. That's actually a rule in BC. Like, you basically have to come every single day. When I heard that, I was like, geez, my methadone clinics are better than that. We are in a very expensive pharmacy, I'll tell you. But our methadone clinics have people come once a month, twice a week, or twice a month, twice a week. Like, there's a wide spectrum of how infrequently you have to come to our OTPs. But those pharmacies in Canada, every single day, that's a giant pain in the neck, right? And they have to subsidize those pharmacies very heavily to get them to agree to do it. Does anybody know how much they're paid per patient per dose per day? Does anybody remember from our talk? I think it was between $14 and $17 a day. That's the Canadian health system.
Per person or
per person, per dose, per day. Do the math, my friends. And that's what it takes to get a pharmacy to say, sure, sign me up for that job, right? You have to incentivize in a way that's going to basically break our medical system. So what pharmacy is going to do this, my friends? Right, okay. Problem one, problem two. Let's do the third problem here, right? So again, it is actually really easy for me to argue that this isn't going to work and that we shouldn't be in favor of it. I think people thought I couldn't do this. I can absolutely do this. Okay, I have pharmacists in the room, so they're going to correct me. Okay, methadone comes in very few formulations. Okay, let's do the one that we all know who run methadone clinics, the liquid, the giant liters of liquid, right? Turn it over. There's a machine that has a very expensive electronic medical record that tells the dispensing machine how to dispense, right? Those things cost tens of thousands of dollars a month, by the way. They stink and they're expensive. And so liquid methadone is going to be very hard for the average pharmacy, if you're doing pharmacies all across the country, to really access, okay? There's first thing. Secondly, the pills come in a 5 and a 10 and a 40 milligram trophy, which I've never laid my hands on. Not available. Okay, right there. Okay, ready? We just got to 5 milligrams and 10 milligrams, okay? So can you imagine a pharmacist who doesn't feel comfortable dispensing 60 milligrams of buke to somebody, handing somebody a bottle with 900? It's not going to happen. We do not have the right formulations of methadone to make this happen. We just don't. And nobody's talking about it, right? Where is my independent generic drug company manufacturer out there talking about this? Because I want to pause and just really, this matters. We got to change this. Thyroid replacement. Family doctor, right? What does thyroid replacement come in? Everything on the planet, though, right? Every single dose imaginable, right? I was reviewing how I treat hypothyroid, and I'm like, on Sundays on a full moon, you should get 1/4 of a 25 plus your 100. So when you do thyroid medicine, a cheap generic drug, for those of you who aren't in primary care, it comes in 15 different doses, at least 10 different doses. We actually need that for methadone, right? We need a pill that's 100, we need a pill that's 25, for this to work. And nobody, who's going to do that? It's a generic drug, right? It's orphaned, like who's really going to do it? So it's not going to work, it's not realistic in today's society, and in the meantime, we have got to support OTPs to be actually doing their jobs well. We need to be putting pressure at every single level to change your local OTP. I need every fellow in this room, everybody who's primary care, doing the practice pathway to become an addiction doctor, you need to be looking at your local OTP and saying, I should be working there. I should be changing the game for our patients, because we can't tolerate this anymore. We really can't. I mean, I'm embarrassed when I hear what happens. Sometimes at my own OTPs, but at my neighboring OTPs. It's not normal standard of care medical care. When people get fired for, we all know, every one of us can tell 28 different stories of terrible things we have heard happening at a methadone clinic. And we need to be spending research dollars looking at outcome measures for methadone clinics. Because what matters more than anything else? Just staying in treatment. What matters more than anything else is that people get their methadone every day, whether they do it under observation or whether they take it at home. That's the only thing that matters, because it restores lives, it restores health, and it prevents death. And if your methadone clinic is not making massive changes, is not doing, when Ingveld Olsen came out with the new rules on take-home bottles should have been flying out of buildings. It's not what it looks like. It is not what it looks like. So for those of you who are researchers in the room, this is the stuff we have got to be looking at. Because people are measuring all the wrong things in methadone clinics, and we have got to start influencing their outcomes.
No slides for this one. I grew up in Washington, D.C. I grew up in Washington, D.C. at the time when Marion Barry was the mayor. Who knows Marion Barry? Who doesn't know Marion Barry? I actually want to see those hands more. Who does not know Marion Barry? All right, so Marion Barry had a drug issue himself. Cocaine was the main thing that was pit passed, but he used some opioids as well. I was in school with Marion Barry's son when everything was happening. And I say that to say this is not about the medication. This is about what happens to the son that's ridiculed by his classmates because of the stigma. This is because of the depression and other mental health issues that the family goes through, the mother goes through, the son who ultimately dies later on in his life because of that. This is because of who does not get the treatment because they're ashamed to get it later on in life as well. And a city that is ravaged by it, that doesn't have access to it at all. I grew up in DC, and that is why I do this type of work. This is not about solely regulation, because it needs to change. I appreciate all the great work that's been done to change it thus far, but none of this addresses the comorbidity of psychiatric issues at all. If family practitioners want to treat bipolar disorder, I want you to. but I know a lot of you are not ready for that. Pharmacists, same thing. Nicotine intoxication with vaping on top of all this. We're not there yet. So it needs to change, but not just because of the medication, not just because it'll be Breaking Bad, the federal edition, as I experience it every day. But because more people need to receive treatment, not just the medication, but civil, unstigmatized treatment, so that the next generation doesn't have to think about it this way. They can talk about it just like diabetes treatment or thyroid treatment or everything else. And we just aren't there with our current regulations. They need to change. But I will say that my experience is if we just focus on the medication and change that without looking at what they all need, how to access everything, what's getting in the way, this conversation's not going to happen about. So let's dig deep as we make these changes because they need to be important and they need to be reflective of the people that are affected by the disorder, not just the ones that are in the choir. And that's going to take some work. So, thank you.
Excellent job, both of you. I would say, would everyone vote they're both winners? I'm really impressed that you both were able to argue both sides so compellingly and passionately. It was really enjoyable to learn from and reflect on. And now I want to take a moment for both of you to have a moment to reflect on the presentations that you both gave and any final thoughts you might have.
Do it right. Whatever it is, do it right. If you're going to treat wholly, don't just focus on the medication. I think it's a very, very critical tool that has a lot of political issues with it and baggage with it, all the way down to name Dolphin. However, you got to do it right because medication alone is not the issue. There's much more to it, and recognize your limitations. We as practitioners may not be able to solve all of this on our own. I was in a talk yesterday where a person said, part of step one in AA literature is to just recognize you're not the person who can do it all. It's not about who the person is, but just recognize you're not the person who can do it all. And I think we have to recognize that. As this changes, just make sure the bigger picture is recognized as well.
You guys see that, when Dennis and I first met each other, we're like, wait, we have to argue what in this audience? Because I have to say, walking in, I actually think most people in the room think there should be deregulation. And it's totally unfair. It's a setup, right? This whole thing is a setup. If we'd been in front of ATOG, though, as an example, right, their conferences, anybody go to that conference in Las Vegas? Okay, good. Okay, I know who's going over. More of us need to be there, actually. More of us need to be at the table. And that's a problem that it isn't. So there's a reason we set it up this way, because we knew we both felt similar ways about it. Firstly, the most important things, we should be asking people who actively use drugs or might receive treatment at a methadone clinic really what they think. And Dennis did say that, because actually going to a pharmacy does kind of suck. It really does. Pharmacies are not great places to go. And one of the things we've heard about Canada is that they really have like a different path for people on methadone, and that they feel discriminated against in that building too. Again, having it more widely dispersed at pharmacies is not going to solve the problem of discrimination. It could be worse. And I feel really strongly that the first step, while we're trying to fight all this other stuff, I don't think MODA is going to pass. I don't think it's going to pass this year or next year or 3 years from now. And even if, for those of you who saw Paul Jogge's excellent poster on the subject, if it only goes to board-certified addiction people, we have really not expanded access much at all, right? Like, we just haven't. So there's another problem with MODA. But so one, we need to ask people who are in treatment or actively using or have thought about going to treatment and don't want to go what they think, and they're not often at the table. We need to do that more. In the meantime, OTPs need to be better at their jobs, period. They need to be better at their jobs. And we need to work on that. And I know that they're, whatever percent, 65%, 72% are owned by for-profits. That's actually not an excuse for me anymore. I don't care that your overlord is Bain Capital and that your decisions are getting made in Kansas or whatever. I'm not putting Kansas in the bus. I don't know where decisions get made, but it's actually not okay anymore, right? And that all of us have got to do our own internal outcomes. How long does it take to get an appointment? If the answer is like more than a day, something's wrong with the clinic. You know what I'm tired of? I'm tired of methadone clinics having 5 hours of doctor's times a week. Like, they make plenty of money, you guys. They do, I'm sorry, they're making money hand over fist. I know that because my methadone clinics, and I work for a poor mental health organization in Western Mass, we're financially fine because our methadone clinics make money. And we are staffed at our big methadone clinic, we're open 12 hours a day to do walk-ins. And I say to my team, it's a medical emergency. Unless you're dying, you never would say no to somebody who needs help at that moment. I don't care what time it is. If they are walking in for help, you're going to see them that minute because they need you right now. And what do? We pay full-time people to staff these places, right? So these 5 hours a week or whatever it is that people work is crazy to me. And what Dennis said, and what was said yesterday by so many smart people, you have got to be doing all the services right there on site. HIV, Hep C, syphilis. We do so many penicillin injections at our methadone clinics right now for syphilis. And basic primary care, because in my world there's no primary care doctors, and our people need their other meds refilled. So all of that's got to happen, and it's not supposed to happen in a methadone clinic. You guys know that? Like, you're not licensed for primary care, you might get in trouble, but at the end of the day, you got to do the right thing by you and by your own personal license to take care of the person in front of you.